behaviors, fluency disorders, or stuttering. So first we're going to go to etiology. There is currently no known etiology for fluency disorders. Theories of fluency disorders have been built on environmental, genetic, and neurophysiological observations. However, none is universally accepted. So first, the cerebral dominance theory. According to this, people who stutter are less likely than their fluent peers to have developed unilateral cerebral dominance and are often ambidextrous. So because of this, they stutter due to this lack of unilateral cerebral dominance. According to Bruton and Shoemaker in 1967 of their two-factor theory of stuttering, stuttering is an involuntary disrupted speech resulting from negative emotions in the speaker. Part word repetitions and sound prolongations would fall into this category of disfluencies according to this theory, while all other forms of disfluencies are considered operantly conditioned speech disruptions. So the negative emotions are what's underlying the repetitions and prolongations according to Bruton and Shoemaker in this theory. The diagnosogenic theory attributes the disorder to a misdiagnosis of normal disfluency in a young child. The resulting anxiety exacerbates the disfluency and establishes the stuttering as a disorder. According to the demands and capacities model, each person is born with various levels of innate capacity to speak fluently. Some people have less of this fluent capacity than others, and this genetic predisposition is what's interacting with the demands of the speaker's environment, and when the demands exceed the speaker's capacity, stuttering may occur. So some speech characteristics, there are primary and secondary. The primary ones are repetitions, which can be part word, whole word, or phrase. Prolongations or blocks, which are also silent prolongations. And some secondary characteristics include interjections, sound or syllable, word or phrase interjections can fall under those. Broken words, incomplete sentences, revisions, circumlocutions, groping, and tremors. And then here's some assessment approaches for stuttering. In addition to standard procedures such as hearing screenings and orofacial examinations, there are crucial considerations essential to the assessment process for fluency disorders. It is important to obtain a detailed case history by interviewing the client and family members and caregivers. The following information should be gathered by the SLP for stuttering. The onset of stuttering and any circumstances possibly associated with the onset. Subsequent course of the stuttering, including its severity, variability, and stability. Familial prevalence. Prior clinical services and treatment procedures, effects of previous treatment procedures, if any, current, past, or future education and occupation of the client, depending on their age, and general health history. A clinician may conduct an assessment of the frequency and types of disfluencies presented in the individual speech by recording an extended conversational speech sample with the clinician and or a member of the family. And recording of an oral reading sample with appropriate reading material for the client is also another option for assessment. A sample may also be obtained of speech produced in various situations for the speaker to assess environmental influences. And the clinician may also ask the client or caretaker to rate different speaking situations in which the severity or frequency of the stutter is variable. In the assessment process, the clinician should take note of all secondary characteristics, avoidance techniques, and motor behaviors. Speech rate can also be assessed by counting the number of words or syllables spoken per minute. And lastly, we're just going to go over some treatment methods. It should be noted that they're not necessarily effective or known to be effective by themselves and should be used in conjunction with other treatments. So first, psychological method. This method of treating disfluency disorders is driven by the underlying theory that stuttering is a psychological disorder. This kind of treatment would involve a great amount of counseling and discussion. These discussions would touch upon personal issues the individual holds associated regarding his or her stutter, feelings, emotions, and attitudes towards the stutter, and possible resolutions of potential psychological conflicts. The fluent stuttering method, derived from Van Riper in 1973, or the stutter more fluently approach, aids the speaker by modifying the severity and the visible abnormality of the disfluencies. The goal of this method is not necessarily to achieve normal fluency, but less abnormal stuttering. This kind of treatment would involve teaching stuttering identification, desensitizing the client to his or her stutter, modifying the stutter through the use of cancellations, pullouts, and preparatory sets, stabilizing the treatment gains, and counseling the client. Fluency shaping method. The goal of this type of treatment is similar to fluent stuttering method in that it aims to stutter more fluently than to obtain normal fluency. And this is done through the teachings of airflow management using easy phonation and a reduced rate of speech. The fluency shaping method also implements maintenance strategies not only for the speaker but for surrounding family and friends. The fluency reinforcement method is in which the clinician arranges a pleasant and relaxing therapeutic environment in which he or she will positively reinforce fluent speech with verbal praise or tokens. The clinician would model a slow, relaxed speaking rate that ensures stutter-free speech. Masking and delayed auditory feedback techniques have been known to improve fluency in those individuals who stutter. Using this technique, the clinician will determine a duration that is client-specific to ensure stutter-free speech. The client will practice this for varying lengths of time to eliminate stuttering. The delay is then faded in gradual steps to reshape normal prosody while maintaining fluency. And lastly, the direct stuttering reduction method seeks to reduce fluencies directly without teaching modification techniques or any fluency skills in particular. Methods in this type of treatment include timeouts, in which the person who stutters is taught to pause after each disfluency, and response coughs, where a token is removed after each disfluency.